Kia ora. Welcome to the New Zealand SimNurseNZ podcast. My name is Erin.
And I'm Alison.
And I'm Marie.
We are the three nurse educators from the Douglas Starship Simulation Program based in Auckland, New Zealand. We're all passionate about our work, and so we'd like to welcome you to join us as we have a range of conversations about all things sim.
Tēnā koutou, tēnā tātou katoa. Kei ngā maunga whakahi, kei ngā wai tukukiri, kei ngā mā tawaka o te motu, ka nui te mihi kia koutou. To those who connect to the mountains, the rivers and oceans across the land, hello and welcome to you all.
Welcome back to SimNurseNZ Season 2. Pretty pumped. Today we are incredibly fortunate to have with us Dr. Todd Chang from LA Children's. It's Sunday for him, so we are incredibly grateful to have him with us today. Todd is a pediatric ED physician, the SIM medical director and director of research in SIM at LA Children's, and he's also an associate professor of pediatrics at Southern California. So welcome, Todd. We're incredibly grateful to have you here. And today,
thank you so much.
We're going to be talking about research in VR simulation, which is definitely a topic of interest to us here. So, Todd, can you tell us a little bit about what VR simulation actually is?
Sure. First of all, thank you for the lovely introduction. So I think most people know what simulation is, right? That's part of what it is. But VR simulation is essentially the use of virtual reality or any extended reality device, typically nowadays with a headset, possibly with controllers or your hand, that makes the simulation happen in the digital realm. So that's essentially VR simulation. What's interesting is that when people do delve into VR from the sim side, you're also going to meet people who are very proficient at your hospital or your nursing school in virtual reality, but applied to patients. So we're separating here VR that's meant for providers, whether it's nurses or physicians, other care partners, versus VR that's aimed almost like therapy or therapeutics for the patients. So there's kind of a divide between the types of people who work on VR, and I think VR simulation involves people who are familiar with education, nursing education, clinical education, and simulation.
And so how do you use VR, Todd? What is it that you're up to with it?
Besides online shopping, which is really cool. Yeah, that's a whole nother concept.
Really? I've never thought of that. That's
well, because you can rotate things and see, clothes from the different angles.
things like that I never think about in terms of VR.
Right. And I guess, it's not really a digression because the advantage of VR over any other medium, because you could online shop on a computer, on a phone, but virtual reality allows a lot of 3D movement, natural 3D movement of yourself, as well as 3D movement of whatever the object or thing is. Particularly in our simulation center, so at the CHLA, Las Madrinas Simulation Center, and I'm using the full name of it because the Las Madrinas organization sponsored the construction and the maintenance of our sim center. We're really grateful for them. We have introduced virtual reality and its technologies almost as an adjunct. It's not a standalone. It was a standalone when we couldn't do live simulations back in the early pandemic era. But right now we use it as a supplement, as essentially an extra simulation. Cool. We use it particularly when typical simulations or standardized actors are insufficient or less cost-effective. So, for example, things that require a lot of 3D anatomy that's difficult to make, like surgical simulations where once you cut, you're done. You have to build a new one. So VR and digital simulations are excellent for those, so you can just hit the reset button and come right back to the beginning.
Yeah.
Right.
We also use VR when we really need a psychologically controlled stressful scenario that isn't too stressful and overwhelming.
Yes.
So VR allows you to fully control the audio visual input, like complete control. So you know exactly what extra noises they're having. You know exactly what extra conversations you can implant. So we've actually explored that in virtual reality in terms of psychological safety, psychological fidelity, and also stress inoculation. So I like to use our emergency department virtual reality simulations for those of us who are pretty experienced, but they go on maternity leave or paternity leave, and they have a shift tomorrow, and they're like, just want to just try this out. I know the science, but it's just been a while to be in that environment. So we like to recreate that kind of environment in VR.
I could see that would be really, really helpful, eh?
Yeah, and often in terms of the audio, or certainly the visual stuff, sometimes that's the hardest part in terms of fidelity creation, I think. For so much of what we do as clinicians is visual. So much of the information and inputs that we get are visual, and kind of merging those two things in a really non-hokey way is that's so powerful, you know?
I think the return from maternity leave is definitely a thing. Both times I returned back to working clinically in ED after having children, I can definitely recall just that rustiness feeling, and just the feeling really out of your depth and wanting to upskill yourself. And so, I could see that being super, super helpful.
And there's no, for those folks who have the knowledge, it's not like you need to relearn how to put in an IV, it's not like you need to relearn those skills, but it's the environment in which you have to reacclimate to.
Yes.
There is nothing for people like that. There's nursing school classes, there's refreshers, there's skill training, and then what of those people who take, whatever leaves, however long the leave is. So it's a different frame shift of using simulation to simply recreate this, the environment and context to reacclimate, while the science or the difficulty of the scenario isn't really high. I think that's actually it's a presence type of feeling with VR. And what's interesting is that with VR research, I know we're going to get to that soon, the patient-based VR research is heavily focused on recreating the environment for PTSD, so post-traumatic stress disorder, and just like introducing things that otherwise would be triggering, but in an extremely controlled, safe manner. And so there's actually a good amount of literature in that realm. And so as we said, VR for sim is different technically than VR for patients, but the concept of how VR works can be applied in both directions. And that's actually what's fascinating. For those of us in VR simulation, you get to pull from a slightly different literature source or expertise, where a whole bunch of clinical psychologists have some really good results already.
Yeah.
That is so cool.
Yeah. So in terms of research, what have you done so far? Like, I know you've done heaps, but...
nothing.
I keep that question really broad because I want you to choose what is the stuff that sticks out for you.
Right, yeah. So the background is that I got started in VR research about 2015, 2016, and credit goes to one of my colleagues who's now in a different location, Dr. Josh Sherman. He and I got together and was fortuitous enough, and this is what happens in California, is that you have all these startups, companies just like wandering around. And at the time, Facebook, which is now currently Meta, had acquired Oculus, the initial headsets, and they wanted to do a campaign that showed that you could use virtual reality for things besides teenagers shooting aliens or whatever, right? Which is what we think of when we think of virtual reality and video games. So they did a huge, effort through their public policy team for something called VR for Good. And it's still, I don't know if it's ongoing, but there's still a lot of products that have come out of it. And we are one of the healthcare stories in VR for Good. So we got really fortunate to be paired with them for funding, and then paired with some VR developers, both in Los Angeles and in London, actually in the UK, where we were able to develop VR simulations that simulated the pediatric emergency department, which is where we work clinically. And we actually decided that our focus was stress inoculation. A lot of the things in the Peds Emerge are not difficult, right? The actual elements are easy, but putting it together in that concert with a whole bunch of things screaming, that's when it gets really, really difficult. And so we wanted to develop a VR simulation that really had that stress context that you could actually ramp up and ramp down so that you can practice these what seems simple in a much more difficult context. So that's my particular research of interest from 2016 to 2019. So we were able to show quite a few things where we measured stress physiology during virtual reality with salivary cortisol levels and heart rates. At the time, Fitbit was just kind of getting to be a thing, so we started measuring heart rates with simple watches. And then, it wasn't quite there in 2015 for research at least, but now it's pretty readily available. And we were able to show that VR does not have as much of a stress response, even though we cranked up all the stretchers and the that pulse ox, right? That you guys all know what that means. Oh, we got it down to, and everybody. Yeah, and everybody notices everyone's heart rates go up, but they only go up by about 6 point something for on the VR side. But when we measure it in the real resuscitation, when a child is actually crashing, it goes up on average of 13. So we didn't quite get to the full-on stress of an emergency, but at the same time, I guess that's okay. That wasn't our goal. People were coming in on their off day in shorts and putting on a VR headset. They probably won't get to that level of stress anyway. Right. So based on our findings, we found that the way that the virtual reality stress inoculation works is excellent for beginners who need a safer environment than the actual emergency department or A&E. And it's great for people who just need that stressful context, like folks coming from leave. Right. So that's what's been happening before. And then my current research, which we just had another enrollment last week, involves a neonatal resuscitation virtual reality program that we're studying. It's coming from a company in Vienna called Summer Reality. Full disclosure, we don't have any connections to the companies except for like third-party, federal funding, things like that. And we're looking at the effect of 1-player versus 2-player.
Oh, cool.
Yeah. So now a lot of companies and software for VR, you can take it home. It's easy. It was a great pandemic response. If we couldn't come in, no big deal. Right. But then, 1-player video games and 2-player video games do different things. And so our hypothesis is that there's something about the 2-player interaction, even if you're not in the same room, that allows for certain communication techniques to be rolled over. Whereas a 1-player and you're talking to a computer avatar, yes, I will put on the pulse ox. Thank you. Hokey. That level of communication means that if you get trained in one of those, that you might know all the science and the algorithms, but when it comes time to interact with humans, it will be a little bit more, I don't know about robotic, but at least definitely not as rich, or perhaps closed loop feedback will be a little bit of a challenge. So that's our hypothesis.
I think we even found that, didn't we, Erin, when we had a go on SimX at IPSS? Yeah. And the two of us were in the same room together and we're communicating with each other. Have you done that, Erin? No, have you done that? Oh, do you want to do this? And I think just having that it just brought that realism to, a simulation.
It was a totally different experience from single-player VR.
Yeah. I'm just interested, Todd, because when you did the research and the stress response of the VR compared to like a real situation, is there anything that compared it to traditional mannequin-based simulation? Was it the same kind of response, or was it more of a response with the VR compared to mannequin-based simulation, or was it kind of on a par? Or
so to directly and indirectly answer your question. So directly, no, we did not look at mannequin-based simulations of stress physiologies. There was a study from Boston Children's that looked at stress physiology with mannequin-based simulation of participants versus observers. I believe the observers had less stress than the participants, which makes sense, but it's nice to have it seen. But I'm not aware of a VR versus mannequin-based pure physiology comparisons. We did do a mannequin versus VR effectiveness study, but we didn't do any physiology measurements of heart rates and salivary cortisol levels, which we were not able to see a difference between them and a performance afterwards. But yeah,
I mean,
that remains to be seen.
Anecdotally, do your participants kind of, just on a sort of a side note, anecdotally, do they kind of say to you that they prefer that VR over mannequin, or is it kind of like or is VR kind of like, do you see it as more of it's kind of like the in thing at the moment, so people are it's something different, or?
Yeah, that's a really good question. It's theoretically not for us, but for the marketing and industry people, it might be a loaded question. But for us, it's whatever works best, right?
Yeah.
I mean, historically, when we first started with the VR in 2015, there was an undercurrent which I didn't detect at the time that we want to make sure VR takes over the world, and these statements like VR will take over all mannequin-based simulations and those started getting bandied about, and both Josh and I were a little bit nervous about those types of statements because there's a great amount of science with mannequin-based simulation. So nowadays, instead of comparing VR versus mannequin, which I think people wanted to do for superiority reasons in the past, we're more interested in if VR is better than mannequin, then how and in what circumstance, and in which cases are VR worse than mannequin. We have the general theory that they're more complementary, they have strengths and weaknesses. So direct comparisons, I think, are no longer necessary as long as they are both doing, purported learning objectives and they're used correctly.
Right.
But they most likely will have unique advantages and disadvantages that complement each other. So it's kind of like a very Californian "let's hug each other" response to that question. But yeah, I don't see as many VR versus mannequin sim study topics as much as I did before, where before the VR industry was really trying to prove itself. I think, and it's still young, you're right, but it's not so young. It's not like neonatal, infant, maybe like late toddler, where they're finally actually going to bed on time. Like, okay, I still need to make sure you don't, put things in your mouth, but I can turn away and you're going to be fine.
Starting to find its place in the world.
Yeah, exactly. There's a certain level of maturity. There's certain companies that now have slight legacies, like you said, so that we have a bit of a comparison. Because remember, like before 2015, there was virtual reality, but it just wasn't quite widespread and like this. So it's almost like all the things we learned from virtual reality in the past sort of apply, but no longer. And so that's part of the new things about current VR simulation research is that, okay, there's old school VR that had bad graphics, that wasn't quite what we needed. But now with the newest things, with 2 players, 3 players, what other things can we do? And that's part of one of the topics of interest for VR simulation research,
So is that where we're off to next with VR research? Is that what?
Yeah, so it's less about whether VR works or not. I think there's enough evidence to show that it has an effect if it's used properly.
Yeah.
That is unlikely to be, based on the VR versus mannequin systematic reviews that we've seen, it's unlikely that VR is superior in all things, and it's also unlikely in the other way around. But we have seen, when they do head-to-head comparisons of surgical VR versus mannequin-based or task-based VR, some of them are superior, some of them are not. And it depends on the kinds of outcomes that you're measuring. So it's very heterogeneous. Therefore, the topic of interest is less about whether it works or not, yes, no, but in what case, in what context, and how many times. So it's more of finding the best use strategies versus whether it works, yes, no. I think we've proven that it works reasonably.
Right, it has its place, but where is that place and how do we further define it? Is that...
Yeah.
Yeah. Nice.
Yeah, so I think for VR simulation, that's where most of the research will go, and that's much harder to do, of course.
Yeah.
Right? It's simple to do, a quick Likert scale and say that people feel confident and they enjoyed the VR very much. We needed to get that done to put it into the research world, but so now it's a trickier saying, okay, how do you teach with VR the best?
What is your sense of that? To pick your...
Oh my goodness.
Excellent. Amazing.
Yeah. Well, so VR actually has 3 specific strengths over any other medium, and anything that exploits those 3 strengths is likely to have a good shot at having an effectiveness that is unique. So those 3 strengths are, 1, anything that has to do with 3-dimensional manipulation or rotation, which includes those of us who work with the more 3-dimensional organ systems like neurology, cardiology, and even like a general surgeon inside the abdomen. If the skill sets require you to start manipulating things in your head in a 3D environment, VR tends to be very good at it. There was a study in which you were supposed to play a matching game. You know those matching games where all the cards are face down and you have to find 2 of the same? So they played a matching game that was suspended in a room, a virtual room, and you could navigate it either through a keyboard and mouse, or you can navigate it just using a headset and looking at the cards physically. And they found that when you look at it physically through the VR lens, you actually had better matching scores than you did with a keyboard and mouse. You had better memory, or at least execution of memory. The theory was that these natural head movements, these natural hand movements that we normally do to absorb our world and learn from it is more natural and therefore better than if you had to navigate the world through a more artificial means like a mouse and keyboard.
That's fascinating.
Right. So there's something... Yeah, right. So there's something vestibular, something natural about movement of the head and interacting in a virtual environment. So if anything has a complex 3D environment, we should exploit it in VR. So there's a fair number of pediatric cardiologists who do a lot of congenital heart anomalies where the aorta is not there and it's going this way and that way, and it's really difficult to actually talk to somebody who doesn't deal with congenital hearts, whereas the 3D anatomists are like really easy. It's really easy with virtual reality. So that's number 1. Number 2, that's that VR could be more advantageous is a thing called embodiment. An embodiment is the act of inhabiting a different character than yourself. And VR is the only medium that you can do this with. There's so you essentially, when you look down, you see your hands, which are your controllers. It doesn't look like your normal hands. Maybe it's a different gender, different color, different species, like tentacles. Who knows? I mean, in the entertainment video game industry allows you to turn into a dragon or an alien or whatnot. But in the healthcare realm, it allows you to turn into a different race, a different gender, different age, and different disability, for example. So that you don't have a limb or you do have a limb or you don't. And so that's called embodiment. There's a fair amount of studies that started from Mel Slater up in Barcelona, and there's many others who have replicated it, where if you inhabit somebody of a different race or gender for quite a long time and inhabit that world and interact with the virtual world while in that space, then you actually decrease the implicit bias that you may have had towards that gender or race. And so, right? And so I know in New Zealand and Australia and the US, we always talk about diversity, equity, inclusion, and we have slightly different meanings of what that means depending on, what the population makeup is where we are. But we've, in the US, there are VR software where you can experience what it's like to be a young black boy in Detroit. And just walk around. Nothing terrible happens to you, but there's these sort of microaggressions that you get to witness that might happen. And it's very eye-opening for people who've never been in that situation.
Absolutely.
And then Mel Slater even has a domestic violence simulation where male-identified individuals occupy the body of a female individual and then essentially confront a male avatar who is not particularly nice. So the scenario obviously stops before anything further happens, but it's that experience that actually changes the mindset of the male individual who probably has never actually experienced that level in that context, right? And so embodiment is something that VR is really looking towards in the patient realm, or not even patients, even outside of healthcare. And embodiment has been brought over to the provider side by I've seen software where you switch places with your therapist. And so you get to watch you watch yourself talk about your own feelings in third person, if you will, or second person.
Wow.
And so that's where VR is very strong at. There's no medium that can do that, literally, right? That's another realm, a quadrant of research that should be happening. And if embodiment is something that you're looking for, VR should be done. That's an advantage that VR has. And then the third item, I know this is really long, but the third item that VR does is it regulates your audio visuals like so precisely, better than any other medium. Even like going into a theater with a movie theater with just a giant screen and speakers, you can regulate their what they see and what they hear, but they can always like pull out their phone and do other things. You really trap them in VR with the perfect control of their audio visuals. And I don't mean it to, it sounds villainous, but I mean it like you're able to curate their level of audio visual psychological stress. And that's the one that I'm really interested in moving things around in virtual reality. And I think a lot needs to happen in that realm. So what is the most appropriate level of psychological stress for a various different level of training?
Yeah.
So those are big.
Powerful.
Yeah, those are big three things that VR is known to be better at than any other medium that we know of in humankind. And so if you can harness any of those three, then VR is a viable option and should be studied.
I'm really fascinated by your, what's your take on AI and how that's going to influence virtual reality? Because, I mean, obviously a lot of it is programmed at the moment and responses are programmed in. But with the introduction of AI, to be able to kind of do those responses, the human factor responses, and the kind of, how do you kind of see where VR is going in terms of things like AI, ChatGPT, all those kind of programs?
Yeah.
Do you think it will enhance it? Do you think it's kind of, because I think a lot of the detractors that I sort of hear from our point of view are kind of like, well, it's not real enough and things like that. You don't get the responses, aren't the same. But I mean, with AI, is that going to kind of help it? Have you seen any advances in that way?
That's a really good question. I kind of want to break it down by saying we were using the term AI kind of loosely, right? It's not just the pure AI programming, but it's the evolution of programs and perhaps characters and avatars that function more and more realistically, right? Or more closer to a human. And I'll preface by saying, for purpose of VR simulation, when you're trying to learn, when a new nurse is trying to learn or a seasoned nurse is trying to learn, it is not necessary to have perfect fidelity. And in fact, that can be a detractor on both cost and just their attention span. So Jeff Norman did a fair amount of work in just looking at sometimes moderate fidelity is all you need to get the learning objectives through.
Yeah. That's definitely our experience too, anecdotally. Yeah, for sure.
Right. And so sometimes we get, I guess we're quite privileged in being able to look at something and say, that's not a very good graphics. When 10 years ago we were playing with pixels, barely with pixels, right? So it's a sign of what we expect in terms of technology in Hollywood and the quality of animation. In terms of using ChatGPT and AI, in the virtual reality setting, which should be the same as most other digital settings for simulation, most likely it's looking at more human interaction or human-like interaction. I think that's what you mean.
Yeah.
And to an extent, I think it's going to be good. There already do exist some virtual reality software to teach empathy, like clinician empathy towards patients. But the earliest software, basically, when it came time for you to speak, just had a couple of menu options one which was extremely offensive, and if you ever picked that, like, why would you be a clinician? And then there's kind of clearly an obvious answer that was very thoughtful. It's like, I hear what you're saying, and I want to address your problems. Tell me more about your blood pressure. Like that. That's obviously the right answer.
Yeah.
So that's very like, in terms of realism, it gets the point across. Perhaps the learning objectives are met by multiple choice. But as things like ChatGPT and natural language and start evolving, and the AI is able to create a conversation with you, then it becomes more and more real, and you can actually practice more empathy. At the same time, when we do VR, you're trapped in that setting. You can always take your headsets off. But in other settings, the AI is on the phone, on the computer. You can always look away, and you're never like completely sucked into it. But with VR, you're fairly sucked into it. And there becomes a point, and this is true with any AI before the current round of AI and natural language processing and ChatGPT, where you hit this thing called the uncanny valley.
Yeah.
Right, where the level of realism is now high enough that it's almost real. There's like one or two elements that you can pick up, but it's at that point it's actually revolting, or you have a visceral negative reaction to it because it's so uncanny. Versus if it's lower fidelity, that it's fake. You can roll your eyes at it, haha, it's fake, but you'll go with it. But there are physical and visceral reactions to when it becomes a little too creepy, right? Creepy is usually the other adjective that's often used. So, when we use ChatGPT and AI to really modify the characters that you interact with in VR, that's what we'll hit. I don't think we've hit uncanny valley in any of the software that's currently out there. At least for healthcare providers of any sort. But will be the next problem. So I think it'll happen. The conversation will get better. You will be able to practice empathy. It'll detect your facial movements and things like that. So it's coming. But I think it will run into an ethical issue, especially if the scenario becomes a little bit more fraught with, death or relationships or something like that.
Just another. So you've got a really successful kind of program, and it seems as though you came into your program with the VR at the right time, and you were approached by Oculus and Meta and everybody. And I congratulate you on the success. How would you kind of give advice to? Because I don't think, and I say this with all due respect to people that might be using VR and these kind of technologies in New Zealand, but I don't think it's quite there. And I don't know whether anybody's, in New Zealand, it hasn't quite gotten the backing behind it yet. I don't think people are quite on the ball yet. There's a few places using, like HoloLens and things. But, in terms of, what would you say to people around the country, not just us, but other places that are looking to use and excited by things like VR, that want to use it but are coming up against barriers in their organisations? Have you got any kind of words of wisdom or of advice or something about how you can kind of approach the stakeholders, basically?
Sure. I mean, that's a really good question. I don't have the perfect answer for you guys, but I can perhaps derive some context and a few learning things that we had. First, the pandemic, at least in the US, did help. I know that your pandemic management in New Zealand was way better than what we had faced. And so there was a moment when there were many sim centers that were just shut down for an extraordinarily long period of time, like over a year. We were fortunate enough, because we were a hospital-based sim center, that they needed us to do COVID simulations. But besides that, there's no other simulations. Regular, life support and CPR training, gone, right? And the schools, the university, the sim centers were all shut down. And so it was during that time when people started looking at digital and home-based VR, or screen-based simulations, distance simulations using Zoom and other technologies. So there was a bit of the the silver lining in the horribleness of how the pandemic compared to you guys in the beginning in 2020 was a bit of open-mindedness towards new technologies, especially VR. So we did enjoy that ride that wave. However, I will also say that you are not alone, and you, the audience who in the podcast, and you talking with me right now, are not alone in facing barriers from stakeholders for VR. I feel it happens all the time. Even my division chief sometimes wonders what I'm doing when I'm playing video games all day and my salary. So that's a whole nother story. But it's, I think the talking points that I'm going to ask you is to really emphasize software and hardware choices that emphasize those three advantages. Right? If there is an equivalent, if there's no difference between mannequin-based simulations and virtual reality, and many of the studies show no difference, and the mannequin-based ones are cost-effective, and you made it that way, then there's no reason to do VR. Like, you shouldn't, right?
Yeah.
It's only if you can show cost-effectiveness with routine VR that that's your talking point. When I usually argue for VR, you have to argue for about 3 years of development and implementation. That's about when you can see cost effectiveness. So typically speaking, with mannequin-based simulation, you have a mannequin already, you have your nurses and educators and your physicians who get together, create a course in a scenario. You've done it before, it's not that difficult. And so there's some upfront cost with time, and then each time you run the sim with mannequins, there's a little bit of cost, wear and tear on the mannequins, the nurses or physicians have to get pulled in for whatever, etc. It's not huge by any means, but over time, over a year, 2 years, it starts adding up. With VR simulations and all digital simulations, in fact, everything has to be constructed or at least furbished if it's not already constructed for you in the very, very beginning. And that incurs a lot of cost, licensing, programming. There's this thing called a burn unit that a game programmer uses. It's $10,000 US dollars that buys you about 1 month of their work. And there's some VRs that requires, 4 to 10 burn units, and that's not cheap. And you don't even have a sim until they're done. Right? So the cost of VR simulations, if you're going to start one, is very high up front. And to the financial people, it looks very scary, right? So especially if you go with a company that's all encompassing, so they give you hardware, warranties, support, plus software licensing, it's going to be very, very high in the beginning. The talking point is what happens after year 1 and 2, where you just double click on the software each time, and there's no setup, there's no cleaning, and the hardware itself is, not that expensive, quite honestly. It's the licensing that's the most expensive part. You actually recoup the cost in year 2 and 3. So that's one of the talking points. So you never be transparent. It's going to cost way more than they were thinking, whoever funds it or supports it. But you have to look 3 years. What is the maintenance plan for 3 years, and how can we recoup the cost by then? That is actually one of the best ways to get somebody to invest in virtual reality, or even a virtual reality space, which takes a lot of space, which, it looks like nothing. And if your area is anything like ours, that looks like wasted space.
Yeah, in our new space, where it's a shared kind of multi-use space. So the space that we have for VR is also going to be a unit space, and it's also going to be a resource space, and it's also going to be all these other different.
Yeah, and I'll caution you, but with hope. When we constructed our simulation center, I asked for one of the large debriefing rooms to be the primary VR room, and so we installed the sensors, and so it's ready to go as a VR room. But we have a lot of conferences, and so I don't get to do all the VR that I want when there's a day-long, refresher course.
Exactly.
Even if they're just like serving lunch, you can't do anything. And so now that there's more and more untethered headsets where you can go to any room, that makes it a little bit easier. But it's not just a geographical thing. It's also a not political, but like philosophical. It's like, do I really have to share?
We know what you mean.
Yeah. But it's
We're all in
we have to
healthcare,
share
it's
with
same
everyone.
old,
I
isn't it? I know.
I don't want to share with anyone.
I don't want to. I don't like it.
Thank you.
Yeah, I think that's one of the big challenges with just VR and even VR simulation research is really getting the place and time and the program situated. But one of the easiest ways, less hardest ways to get it done is to really look beyond year one.
Yes. That's significant.
Be transparent in how horrible it will cost, and then 2, 3 will be much better. There's actually, in 2019, someone published a dollar for dollar cost comparison between a NICU evacuation drill that they normally do, which sounds, a baby in each pocket and run down the stairs, right? That they did for all their employees every year versus a virtual reality version where they just put on headsets and they rehearsed it through. And year one, the cost was way higher on the VR. But and she actually calculates per person cost. Start coming down in year 2, start coming down in year 3, because there's no planning that's required once it's executed. But I think virtual reality is here to stay in whatever its newest form will be. We are going to contend with it and use it to the best of our ability in simulation for a variety of healthcare providers. We have increasing technologies that allows us to use it in different ways than we thought of. Even the use of controllers was brand new in 2015. And then the technologies are dictated by the entertainment industry, not by us.
Yeah, absolutely.
Which is the most important. So that's why every controller has a trigger, because, guns. Whereas there's no reason to use a trigger for us, for most of our work, right? And so we are adapting to what the technology is moving, and it's exciting. It's a lot of fun. There are not that many of us that do VR simulation or VR simulation research.
There's nothing that goes on out there. But
I mean, Ali, even if for everyone here, one of the best things to do if you really want to get into VR is to really talk with clinical psychologists and even neurologists who are using VR for patients and see what their findings are. So we have, not in our children's hospital, but in the main hospitals, the older hospitals where they treat dementia, one of the first signs of dementia is loss of spatial reasoning. And so they use virtual reality as either diagnostic or training, detecting dementia.
Wow, that's cool.
I was going to ask, I know this is kind of like, sorry, I'm kind of digging into your nap time, but I'm kind of just fascinated. When I talked about like AI, but haptics, where do you see haptics kind of coming in?
So VR does not have good haptics to begin with, especially for clinical medicine. It's and haptics is this long. It's a multidimensional PhD level kind of topic where there's different elements of haptics. There's heft, there's hardness, there's force, there's all sorts of things. And then for the majority of things that we do in medicine and nursing or in surgery, especially in my realm with pediatric, it's tiny. They're tiny finger movements, right? And like for those of you who have inserted, hundreds of IVs, there's a certain feel that's impossible to tell somebody. When you feel it go through the vein, even before you see the flash of blood. Like there are those types of haptics that are probably incredibly difficult to replicate. There's not a device for it right now. The standalone controllers are way too big. They bump into each other, and so for a lot of the haptic items, there are other modalities, especially in the AR realm, where you can pass through and see what else is going on in real life. So there's also these AR and hybrid VR where when it's time to touch something with your hands, you actually touch a mannequin or a body part like an arm or whatever, so you can feel those landmarks, but projected inside your visor or headset is whatever it wants to. Maybe it's already bleeding in the headset, whereas it's just the styrofoam thing that you're actually touching. So that's actually a hybrid method that a couple of people have already been doing. As an example, we have a research study with a company called Tetrasignum. It's a Korean company that does VR-based CPR training, where it's just a regular old torso of a mannequin. But when you put the VR headset on, there's a guy who walks down a street, clutches his chest, and goes, "Ugh," and then like plops right where the mannequin is, and then your job is to pounce on the mannequin and start CPR on that man, right? And so there are ways to use real objects to simulate the true haptics, and I think that's where it's going to be the strongest for healthcare.
I mean, just thinking about all this VR stuff, I was trying to teach some students, some new nursing students, how to do a manual blood pressure, and trying to describe what they're going to hear when they pump up and release, and it's just so impossible to try and. But you think, well, if they were in a VR headset and they could hear that at the same time, just kind of seeing what they're doing and then hearing it when it kind of happens, it would make such a difference to that kind of learning experience.
Agreed. The context is key.
For our fellow VR nerds out there, we will, Todd can share how he can contact it or resources and things that we can chuck into the show notes for you. It's been fun. It's been a good time.
It's been really
It's been great. I love it. Thank you. Thanks for inviting me.
Thanks for listening to this episode of our podcast. It was made possible by the Starship Foundation and the Douglas Charitable Trust.
And special thanks go out to all of our amazing guests.
If you'd like to connect with us on Twitter or find out any information from any of the episodes on this podcast, just see the show notes.
Our Twitter handle is @StarshipSimProg and our email is starshipsim@adhb.govt.nz. We would love to hear from you.